Today's webinar presentation will begin in 3 minutes. Today's webinar presentation will begin in 1 minute. Welcome to today's webinar, Management of Sexually Transmitted Infections Among Youth. I would like to introduce Sharon Nachman, MD, Professor of Pediatrics, Associate Dean for Research at SUNY Stony Brook in Stony Brook, New York. Welcome, Dr. Nachman.
Good afternoon. So good afternoon, everyone. Thank you very much for signing into today's talk. If you have not yet previously logged in onto the new website, you'll need to use your new email address and reset your password to make sure that you're logged in. With regards to CME, the IAS-USA designates this live activity for a maximum of 1.25 CME credits. The webinar is also approved for 1.25 hours of credit for nursing, pharmacotherapy, and pharmacy credits. Evaluations will be available on My Activities page by 5 p.m. Pacific time today and not before. Grant support for this webinar has been received from the following contributors: Gilead and ViiV, Merck, Cepheid, with additional support provided by Hologic. So in order to navigate the webinar, we're going to have some questions. A separate window will show the poll questions. Choose your response from the poll, not in the chat box. and responses will be displayed after the poll closed. However, to ask questions, please type them into the chat box. I will be answering all the questions at the end of the webinar. So for the first poll, from which geographic region are you viewing this webinar? Please vote. Almost everyone is voting. Please click. Okay, let's exit the poll and see what the results are. It appears that most are from the Western United States as well as the Midwest and South, with a smattering of other places. Thank you very much for getting on today's webinar. The next question is, when will the evaluation for this webinar be available? Immediately after the webinar, by 5 p.m. Pacific time today, or my favorite, when the moon hits the eye like a big pizza pie. Thank you for those who are voting for that answer. All right, let's end the poll. And it appears that everyone heard me saying by 5 p.m. Pacific time today. Thank you so much. Please rate your level of experience in the medical management of sexually transmitted infections. 1 if you're a novice, and 5 if you're an expert. And it looks like almost everyone has voted. We'll give it one more few seconds. Thank you. The poll is closed, and it looks like most of you are between a novice and an expert. And thank you very much for coming on for today's talk. I have no relevant financial affiliations to disclose as of today. Upon completion of this webinar, the learners will be able to discuss the incorporation of STI screening in your routine care of your patients, review the treatment recommendations for youth, and discuss the use of vaccines in STI prevention, somewhat a new topic for all of us. What this talk will cover is pathogens of interest, a bit about their epidemiology and treatment, what's now out there for prevention, what are some of the vaccines, what are the newer treatment, and what else is coming down the pike. And as I remind everyone, half of all new STIs are in people under age 25. The take-home message for our patients are protect yourself and protect your partner. Recognizing that there's a whole smorgasbord of STIs out there, I'm only going to be focusing on a few of these: chlamydia, gonorrhea, syphilis, and trichomonas. We won't be discussing the rest of these STIs today, but I encourage you to read about them at your leisure. So the first question I always get asked is, how accurate are our numbers? We always talk about how many STIs are out there, but do we actually know what the real numbers are? And the answer is no, we don't. The CDC estimates that youth aged 15 to 24 make up just a quarter of the sexually active population, but they account for half of all of the 20 million new STIs that occur in the U.S. each year. Of these, about 13% of the sexually experienced youth 15 to 25 years who were covered by their parents' insurance plan reported that they would not seek sexual and reproductive health care because they were worried that their parents would find out. This is a problem, and it will become a bigger problem with other insurances and how they change. We need to talk to our patients and encourage them to still get screened, tested, and treating, even if their parents might find out. So what's the incidence and prevalence of cost of STIs? And I find that talking about money is something we don't always do, but it is still important in our medical care. The incidence of 20 million new infections, the prevalence of 110 million cases, including the 8 common infections. The cost then is $16 billion in direct medical costs. So anyone who says, oh, we shouldn't be spending money on that, the answer is yes, we should, and we already are. So let's talk about some of these. The estimated case rates of curable STIs in the U.S., it looks like we're winning. We have 126 million cases of curable STIs out there. and that includes only 4 pathogens. So the good news is we're ahead. The bad news is we're ahead. We need to do a better job on treating these infections. So what is the estimated number of new sexually transmitted infections? And is it changing over time? And the answer is, looking at youth 25 and over and 15 to 24 years of age, we can see some pathogens occur in one population or another, but for the most part, they equally spread between the 2 age groups. What about the state of STDs in the U.S. in 2017? Well, unfortunately, the numbers are increasing. We've got 1.7 million cases of chlamydia, 500,000 cases of GC, and 30,000 cases of syphilis. So anyone who has sex is at risk, but some groups are more infected than others. These include young people aged 15 to 24, the population we're focusing on today, gay and bisexual men, and pregnant women, populations for another talk. So what about internationally? I said we're kind of ahead of the numbers, and the answer is that's not good news. There are more than 1 million STIs acquired each day worldwide. Each year, there's an estimated 376 million new infections with 1 of 4 STIs, and it's the same 4 that we keep hearing about over and over again. More than 500 million people are estimated to have a genital infection with herpes, and more than 290 million women have an HPV infection. If that's not a reason to talk about HPV vaccination, then I don't know what is. So how young you are starting to have sex, of course, makes a difference. The younger ages at the first intercourse were associated with higher odds of acquiring an STI compared to older populations, and the effect diminishes with increasing age. So the kids that start earlier get more STIs than those who start later. That's something we need to talk to our families about as well. When you look at the weighted proportion of participants with a sexually transmitted infection, we look at the age of first sex and notice that that is exactly where they're occurring. So what is it about younger girls' mucosa that makes them more susceptible to an STI? And the answer is this is true. The female genital tract is a complex niche of microflora, and because of this, they are more likely to get an STI than if they're older. Interestingly enough, the upper genital tract is most similar to gut and lungs. It's comprised of a layer of columnar epithelial cells which are joined by tight junctions. The lower genital tract is most similar to cornea, esophagus, and mouth. There's multiple layers of non-keratized and squamous epithelial cells that cover a basement membrane. And as those squamous epithelial cells are turned over, they're renewed from the bottom. And that particular fact is where our STIs are sitting. And here's a picture of it so you can see the endocervix, transitional zone, and the ectocervix. And you know that immune cells in the different areas function differently. And depending where the microbial load is, that's where you're more likely to get infected. Looking at the same type of picture from an immune perspective, there are chemokines, interferons. There's an area that kind of has nothing, that window of vulnerability. And there are chemokines and other factors in the endocervix. Each pathogen has its own way of attaching and being incorporated into the cells and causing infection. And depending on the immunity cells at that area, you will get infected or not. So what else contributes to these high STI rates? Well, there's substance abuse and mental health issues. There's a complex structure of sexual networks, of which I've tried to show you pictorially. And of course, there are older sexual partners, lower level of condom use, and our chief worry about psychosocial development stage in this age group is associated with increased risk-taking behaviors. They are trying to do everything by themselves and not asking or listening to advice. It's all about perception as well. When you ask youth, did you think you had an STI or did you consider yourself having an STI? Many of those reported a negative history of STIs, in fact had a documented STI and treated in their EMRs. 2.7 of those patients had chlamydia, 2.8 had GC, and 6.3% had genital herpes. All of those patients said, nope, I never had an STI at all. So let's look now at each of the individual pathogens. Let's start with chlamydia. This is a map from the CDC looking at rates of reported cases by county in the U.S. in 2017. Obviously, the darker the number is, the more the cases were. So if you're living in a state that has a lot of dark blue, you know this is the population that you're seeing. When I break it out looking at males and females, you see there's some changes on that map originally. There are some states that have more female population, some have more male population with this STI. But there is a great degree of overlap in those populations. Let's think about the pathogen for a few minutes. Let's talk about chlamydia. Number one, if you have a patient that has chlamydia, this is a reportable infection. Your Department of Health is going to want to know who that patient is. It is a gram-negative bacteria. There are 18 serovars. Some of them cause eye disease, some of them cause genital disease, and some cause other diseases. Chlamydia infects columnar epithelial cells, and as I've shown you earlier, that adolescent female is at particular risk because of the presence of that squamno-columnar junction on the ectocervix. So at any time until they're an adult, they are at high risk for acquiring this pathogen. There's a unique biphasic life cycle for chlamydia that makes it, interestingly enough, adaptable to both intracellular and extracellular environments. And most importantly, an infected male has a 1 in 4 chance per each sexual encounter of transmitting the infection to an uninfected female. So if you find an infected male, you must treat them and tell them to abstain from sex right away. Will they listen? I don't know. What about diagnosis? Well, for those sexually active women under 25 years of age, annual screening is recommended. What test should you do? You should do a NAT test, are the most sensitive tests. NAT tests are FDA cleared for use with vaginal swab specimens. Do you have to collect it, or does your patient self-collect? And the answer is, it is independent of who collected it. The specimens are equivalent in sensitivity. So if you aren't able to collect it, your patient can collect it and bring it into the office. You can also use first catch urine in men, as well as a rectal and oropharyngeal infection specimens. You have to test at the anatomic site of exposure. Unfortunately, the NAT testing is not FDA cleared for rectal and oropharyngeal infection testing, but it is still used. What about treatment? Well, there are first-line treatments and alternative treatments. A meta-analysis of the first-line treatments shows that doxy versus azithromycin are probably equally as good. So you can use either one. Dosing for the azithro is 1 gram PO times 1. For the doxy, it's 100 milligrams BID for 7 days, or delayed release tab 200 milligrams daily for 7 days. The alternatives, including erythromycin and levo, have no good data on how effective they are. So we strongly recommend using azithro or doxy as first-line therapy. What about reinfection? Obviously, this occurs. Any patient that you've tested must be retested at 3 months' time. Do not send the NAP testing under a month because you're still going to have some residual positivity despite therapy. Telling patients to avoid sex for 7 days after treatment is really important to avoid reinfection. But of course, will they listen is always the kind of question. And as the cartoon says, you have all kinds of amazing things in your utility belt, but no condom, no sex. The next steps for chlamydia are prevention. In infectious disease, while we're really good at treating, we really want to prevent the infections from occurring. So how are we going to prevent it? Well, vaccination is what we talk about. A safety and immunogenicity of a chlamydia vaccine candidate recently was published in the Lancet Infectious Disease in August of 2019. This was a randomized, double-blind, placebo-controlled trial, and it was a phase 1. And what they did, which was very interesting, is a prime boost strategy. They gave an IM shot at 0, 1, and 4 months, and then they gave intranasal dosing at 4.5 and 5 months. And why did they do that? because we've already talked about the similarities of the epithelium on the different parts of the cervix and ecto and endocervix compared to the different epithelial linings of the patient. We already talked about this. The vaccine had been evaluated in mice, pigs, and non-human primates, and there was protection in those populations. The immunization schedule with systemic priming followed by an immune response was highly effective in inducing mucosal immunity and induction of IgA. We don't have the answer yet on how well this vaccine will do moving forward, but at least it's a great first step showing that you can use a prime boost with different types of mucosa covered to actually get antibody production. Moving ahead to gonorrhea, we again look at the CDC maps. The darker blue are the areas that are most higher rates of infection. Splitting it out by male and female, we again see different rates in the different states in the U.S. So depending where you are, you may be seeing more male cases or more female cases, but there is a fair amount of overlap on both of those populations. So what about the pathogen? Well, this is a gram-negative diplococcus. It's kidney-shaped. You've all seen this in slides, whether in medical school, in pharmacy school, or in nursing school. Neisseria gonorrhea typically infects mucosal membranes and may remain localized, but can also disseminate. What are some of the manifestations for dissemination? Well, we get urethritis, epididymitis, and proctitis. We still see conjunctivitis, PID, pharyngitis, and disseminated infection. I remind patients all the time that oral sex does lead to pharyngeal infection. Vertical transmission can occur, and gonorrhea can also increase the rate of HIV sexual transmission up to 5-fold. Having 2 STIs, one of them being HIV, accelerates the infection for both. So what about the pathogenesis and clinical manifestations of Neisseria gonorrhea? Well, this is a very, very smart bacteria. It can easily prevent complement activation, opsonization, and bacterial killing, the things that our bodies like to do to get rid of bacteria. It's very smart. It evades the host. It still can cause cell damage, and you don't even know it's there. How do you make the diagnosis? Well, the first thing you're supposed to do, like any other illness, is talk to the patient. Do they have any dyspareunia, any vaginal bleeding after sex? And on exam, yes, we encourage you to touch your patients. Do they have inguinalopathy, any cervical motion tenderness, or mucopurulent discharge? Don't forget to ask about arthritis as well as any fevers making you think about septicemia. How are you going to make the diagnosis? Well, there are presumptive tests and confirmatory tests. First, you must take a specimen and do a direct smear and look for a gram-negative diplococci. You can incubate them, you can grow them, you can see them on microscopes. There are typical testing that we do for them. And when you have a positive, you know it's real. A negative, you might recheck with another method or make sure that your specimen was in fact correctly sent. But it's not all about culture because this bacteria likes very specific temperature, humidity, and growth media. Gram stains of exudates may not be so helpful, and in some studies are only positive in about half the women who in fact have a pathogen identified. So again, like chlamydia, we're going to use rapid testing such as NAT. The swab can sit for 48 hours in the refrigerator, and it has high specificity and sensitivity. So if you're doing testing for STIs, you're going to be using NAT testing on your population. Well, what about treatment? That's the $64,000 question because pathogens are always smarter than the people. And that's part of the mess that we're in now because there's so much resistance. And as the cartoon says, due to abuse and overuse of antibiotics, we're going to see more and more resistance. That which does not kill us makes us stronger. Nice message for us, but not so nice to hear from the bacteria involved. So let's take a quick look now at the susceptibility patterns of Neisseria isolates to antimicrobials. This is from the Gonococcal Isolate Surveillance Project from 2017. And as you can see, about half of them in blue were susceptible. Then, moving around the circle, you see anywhere from a third to 10% to 5% that were only susceptible to a single antibiotic. That's a very big worry for us because the more antibiotics we use out there, the more likely that we will see Neisseria that are resistant. Looking at the prevalence of tetracycline, penicillin, or fluocinolone resistance, or elevated resistance to cefixime, ceftriaxone, or azithro, we can see that year by year, the resistant levels are going up. And I've drawn a blue arrow at Cipro because over the past 7 years, we've pretty much lost the ability to use any Cipro on patients that have Neisseria. If you looked at 2001 or 3 or 5, you could use it quite easily. Now we're in at 40 to 50% of all of our GC being resistant. Looking at the distribution of primary antimicrobial drugs used to treat GC from the gonococcal isolate surveillance project from 1988 to 2017, you can see that we've basically lost multiple antibiotics to be able to use them for GC. There's no Cipro that we can use. There's really no gentamicin. We can certainly not use a whole lot of other cephalosporins. And the only thing that we're really left being able to use now is some high-dose ceftriaxone. That's not good for us because we may lose that in the future too. This is a slide that I'm not going to read that talks about how many different groups are actually looking at surveillance. And there are groups that are in the U.S., groups that are abroad. All of these have open access websites, and I encourage you to look at some of them as they pertain to the populations in your state. So what are the guidelines? Well, for urogenital, pharyngeal, and rectal GC, the recommendation is ceftriaxone 250 milligrams IM times 1 plus azithromycin 1 gram by mouth. The alternative regimens, you must perform a test of cure after 14 days because I've already showed you that there are big gaps on how well they will be effective at treating your GC. What about new therapies? Well, with the increase in resistance, we need some new antibiotics. And actually, to our surprise, there are some interesting ones coming down the pike. Lefamulin is a recent approved antibiotic licensed for community-acquired pneumonia. It comes as oral tablets as well as injectable, and it inhibits protein synthesis and growth. There's a lack of cross-resistance with other antibiotic classes, and for us, very exciting news, it's active against all of the resistant GC isolates out there. Unfortunately, we don't have any data yet on dosing, pharmacokinetics, or pharmacodynamics, but I am hoping that sometime in the next year or so, we will actually get data on this and understand if we need to use lefamulin, how can we use it for our GC-resistant patients. But looking ahead, again, we really don't want to just treat, we want to prevent. We're running out of these antibiotic options, so we need to get a vaccine. Who should get this candidate vaccine? Is it everybody? Should it be universal coverage, just high risk? But do we have any vaccines out there that can give us a hint as to what we can use? And the answer is, of course, there's a story here on the meninge B vaccine. And let's look at that for a few minutes. Meninge B vaccine was developed because we were seeing a lot of type B meningococcal disease worldwide, but in particular in Australia and New Zealand. And the guys in New Zealand developed a meningococcal B vaccine to combat an epidemic of meninge B disease that they were seeing. It included an outer membrane vesicle, a serogroup B meninge, and it was offered to anyone under 20 years of age for free. And surprisingly enough for us, the estimated vaccine efficacy against GC was 31%. So by luck or not luck, fate, in fact, this meninge B vaccine that they used in New Zealand and Australia also protected against GC. Currently in the U.S., we have Bixero, which is approved for ages 10 to 25 years of age. It also includes a meninge B outer membrane vesicle and 3 different antigens. And these antigens, which are conserved in meninge B disease, as well as other gonococcal like GC, is protective in animal models. So in New Zealand, they saw a decline in reported GC cases during and after the use of their meninge B vaccine. No other sexually transmitted infections described in their national surveillance reports decreased. So it wasn't by chance alone that the meninge B and the GC rates went down, but it was directly related to the meninge B vaccine that they gave the population at high risk. So the take-home message is, maybe you need to think about giving a meninge B vaccine to all of your sexually active adolescents. There are currently 2 group B vaccines that include these outer membrane vesicles that are in wide use. Both appear to provide broad protection against the Neisseria target diseases, and both are likely to offer cross-protection against GC to a greater or lesser extent. When you go from nothing to something, having something is really important, particularly when we think about the fact that the resistance profile for the pathogen is getting worse and worse. While Bexsero has not been formally assessed against GC, it contains a protein that is really of interest to us and conserved in GC. The provision of a booster dose of one of these vaccines at an age prior to sexual debut may provide a basis for heterologous boosting, and that could be worth exploring as a strategy. And stay tuned, perhaps next year we'll have an answer to that question. Moving ahead to syphilis, this is again a map from the CDC from 2017, with the dark blue being the most cases of syphilis. I thought I would also, instead of just showing you a map, look at the primary and secondary syphilis cases reported by age group and sex in the U.S., defining it between men and women. And as you can see, we see some populations having more and some populations having less. Congenital syphilis is a reflection of syphilis in women. Looking at the reported cases by birth and reported rates of primary and secondary syphilis, we see an overlap of congenital cases and age groups. But of concern is this increasing rate over the past several years. Well, Treponema pallidum, the pathogen for syphilis, belongs to a family of spiral-shaped bacteria, and they're related to lots of other treponemes that also cause other diseases. In the laboratory, dark field microscopy is used. How often have people done that? No. We don't like to do that because it's very, very hard. One factor contributing to treponema's chronicity is the lack of integral outer membrane proteins, rendering intact organisms invisible to the immune system. Again, like other STIs, this is a very smart pathogen. It avoids your immune system and can sit there for years. So let's think about how it presents. Well, there's a primary phase, and this presents with localized lesions a couple of weeks after infection. Maybe you'll get some chancres, some lymphadenopathy, and importantly, it will go away even if you don't treat it. And that's the problem with our patients, is that they don't remember to tell us what they had 3 or 6 months ago. For the secondary phase, we see disseminated illness, and that can develop up to 6 weeks after infection. They may develop with a rash, lymphadenopathy, a headache, or malaise. If that's happening in the middle of flu season and they don't have a rash, everyone will say they have flu. The tertiary phase, about 30% will have late complications, and these include cardiovascular complications, neurologic complications, or granulomas. And I've shown you on the right of the slide here the time course between primary, secondary, asymptomatic, and then recurrent secondary illness, and then long-term disease. And what's very concerning is the time frame goes from months to years. You may have completely missed the primary and secondary phase, but years later, you're getting the tertiary phase. What about pathophysiology? Well, there's growth of organisms at the site of infection at the time of acute illness. For primary syphilis, you'll see a chancre at the site of infection and some regional adenopathy. Secondary syphilis, you'll see the rash, maybe some adenopathy, and then latent syphilis go on to have tertiary or no further complications. How do you make the diagnosis? And the answer is this is a bit of a changing story. The traditional diagnosis or traditional algorithm was a quantitative RPR. For those that were positive, they had a TPA or other treponemal test, and if it was positive, they called it positive. We've moved away from that over the past few years and have done a reverse sequence test using an EIA test. If the EIA is negative, no further testing is done. If it's positive, we'll do a quantitative RPR. Again, a negative and a positive, if confirmed, will tell us. So why did we move from the traditional RPR to the reverse sequence? And the answer is it was all about manpower. The EIA testing is an automated test. Many tests can be run on one plate, and you can get answers relatively quickly by running the entire plate. The traditional RPR requires someone to look at the test. That means a technician must take time to look at each individual test and call it a negative or a positive. With the press of more things need to be done by every tech in the lab, most institutions have moved now to a reverse sequence or EIA as opposed to the RPR. However, if you order an RPR, you will get it. So it really depends on what you're testing, if the prevalence is low or high, and who your population is. What about treatment? Well, for adults, we use benzathine penicillin G 2.4 million units IM as a single dose. For children, benzathine penicillin G 50,000 units per kilo IM, up to the max of the adult dose. Primary and secondary syphilis patients, infected patients, need evaluations at 6 and 12 months post-infection looking for treatment failure. Those with latent syphilis should be evaluated frequently, including 6, 12, and even 24 months after acute infection. What do we worry about? We worry about new infections. Well, we can't afford to ignore the fact that many of our adolescents are also getting pregnant, and they too have STIs. We need to think about primary syphilis in pregnant women, early latent, late, and then neurosyphilis. And these are the CDC STI guidelines for those patients, and I've included how they compare to the WHO guidelines. And as you can see, for the most part, they're very similar. So what should you not use? I've told you what you should use, but you need to remember what not to use. Penicillin G, potassium, or sodium are things that you should not be using. While they will treat susceptible strains of microorganisms, they're really not for STIs. And penicillin G procaine basically includes procaine as a topical anesthetic, but is not what we want you to use for syphilis. Well, if you're allergic to penicillin, what are we going to do for you? The data to support use of these alternatives in the treatment of syphilis, unfortunately, are quite limited. So because of this, there are some therapies that we suggest or discuss, but we really don't have solid data showing they are as good as penicillin. What do they include? Doxycycline 100 milligrams orally, twice daily for 14 days, or tetracycline. Ceftriaxone, 1 to 2 grams daily, either IV or IM for 10 to 14 days, is effective in treating primary and secondary syphilis. However, the optimal dose and duration for ceftriaxone has not been fully defined. Azithromycin should not be used at all. So if someone who has a penicillin allergy and would like to use azithro, the right answer is please don't use it. We often hear about patients having reactions to antibiotic, and they'll say, oh, I had a reaction, I'm allergic to it, I can't take it. Which of these reactions is significant is the Jared-Herxheimer reaction. This reaction is an acute febrile reaction. It presents within 24 hours of therapy. So if you're giving them the dose and they come back 2 weeks later and they have flu-like illness, they do not have a Jared-Herxheimer reaction. It typically is headache, fever, myalgia. Patients should be informed about this possible adverse reaction and how to manage it if it does occur. When does it usually occur? In those patients who have early syphilis, because the bacterial burden in those patients is higher than any of the other presentations of syphilis. Antipyretics can be used, but have not been proven to prevent this reaction. Jared-Herxheimer reaction might induce early labor or fetal distress in pregnant women and should be discussed with those women who in fact do have syphilis. Well, what else is important to remember when you think about testing for STIs and treating them? Can we treat the partners? The clinical practice of treating the partners of patients diagnosed with STIs by providing a prescription or medication to your patient to take to their partner has been approved in some states. And does it work? And the answer is, interestingly enough, it does. So in this map, the green states are when you are allowed to give medication to your patient to bring to their partner. In the orange states are ones that are potentially allowable, and in the red one, it's prohibited. So for that place where it's potential or prohibited, you need to work twice as hard to get the partner in to be treated. What about a syphilis vaccine? Are we there yet? And the answer is no, we're not there yet. The vaccine would need to be efficacious at preventing all stages of infection. It has to be safe to be used during pregnancy. It has to avoid the potential for disease transmission in primary syphilis, where the bacterial load is the highest, and it must prevent latency in the infected individual. So basically, we're asking a lot of a single vaccine. Not to mention that there are numerous Treponema strains that circulate globally that do have differences. So we're not there yet with a vaccine, but hopefully it's coming soon. So let's move on to the next pathogen, Trichomonas. It is the most prevalent non-viral STI in the United States. It is not nationally notifiable or reportable. So while all the others you have to report, this one you don't. How many people does it affect? 3.7 million people per year in the U.S. Infection may increase HIV acquisition risk by up to threefold. Treatment can reduce genital HIV shedding even in those not on antiretrovirals. So there's added bonus for you to treat the Trichomonas, because even if they're not being treated for their STIs, you will cut down on transmission of both pathogens. The prevalence in the U.S. is 2.3 million among women 14 to 49 years of age. But as you can see by the arrow, I pointed out which age groups seem to have the highest burden. And again, it's a population we're discussing today, the under 21-year-olds. 50% of them are asymptomatic. And this pathogen is also a bit of a problem for us because it can survive outside the body at temperatures as low as 15 degrees for up to 48 hours. So thinking where you've been and where you're sitting and where you're going to be sitting is something you should talk about with your patients. There are 3 species out there. Trichomonas vaginalis inhabits the vagina in females, prostate and seminal vesicles in male, and the urethra in both. Other ones, which are non-pathogenic, inhabit the oral cavity and the ileocecal region. So you have Trichomonas in your mouth as well, and they are found in dental pockets and around teeth tartar, but they're not an STI. What about symptoms? Well, men have symptoms of urethritis, epididymitis, and prostatitis. Women have vaginal discharge that may be diffuse, malodorous, or green-yellow, but 70 to 80% of patients have minimal or no symptoms. And these untreated infections last for months to years. Partners of men who have been circumcised may have a decreased risk of Trichomonas infection. Douching is not recommended because it will increase the risk for vaginal infections. What about diagnosis? We're back to our NAT testing. NAT testing is highly sensitive, often detecting 3 to 5 times more Trichomonas than the wet mount microscopy does. So wet mount has poor sensitivity, and it's worse in male specimens. Therefore, the right answer is don't do wet mount and don't send a culture. You should do a NAT testing, vaginal swab, and urine have up to 100% concordance. And the assay can be used with urine or urethral swabs for men if it's in a CLIA-certified lab. Other testing kits are available, but please check with your hospital or your office practice for the test that you are using and look at how sensitive and specific it is. You want one that's doing well. What about treatment? Well, metronidazole 2 grams orally in a single dose is the way to go. For those of you who have never taken metronidazole, it doesn't taste good, nobody likes it, but we still use it all the time. The alternative is metronidazole 500 milligrams twice a day for 7 days. If they didn't like the single dose, they're not going to like the 7-day dosing. Importantly, you must remind your families that for 24 hours after finishing metronidazole, they cannot have any alcohol, and for 72 hours after finishing tinidazole. So both of these will cause increased issues if they're drinking. Trichomonas causes other problems. Among a study which included 13,000 women enrolled at mid-gestation and tested for Trichomonas vaginalis by culture and followed up until delivery, low birth weight and preterm delivery were unfortunately commonly seen. Did metronidazole help to prevent these outcomes? Unfortunately, no. So we don't know, was the dosing incorrect, was the timing incorrect, but having the Trichomonas is associated with low birth weight, preterm delivery, and metronidazole did not make a difference. So in summary, STIs are easily transmitted. You should think about them, talk about them with your patients, treat the patients and the partners. Remember that resistance is a moving target and we always have to worry about it. And looking ahead, vaccines and perhaps the new antibiotics will help treat and prevent STIs in our future. So that's all I had for today, and I'm hoping that we will have some questions from everybody. Thank you. So I see people are typing questions. Please send them in. I'm not seeing the questions that you're typing. There we go. The first question, will you have access to the slides? The slides should be available from the webinar. There's nothing here that is licensed. They're available to everyone. So the next question is, what are the symptoms of oral trichomonas and what is the test? So the answer is you should think about trichomonas orally as not an STI, but only vaginally or rectally or sexual transmitted. The next question is, what does research say about the relationship between PrEP uptake and the increasing STI incidence? And that's a great question and a bit of a moving target. There is some data that with PrEP uptake, we are seeing an increased STI. And is it because we're doing a great job of messaging that you won't get HIV? I don't know. But I think the fact that people are coming for their PrEP and are getting PrEP means that we have access to the population and have to do a better job talking about STIs as well as testing for them and treating for them and their partners. Because if they're taking PrEP, we know that they're in the right place for us to talk about other STIs. The next question is, how should one interpret syphilis antibody EIA test as reactive and an RPR that's negative? And the answer is there's two different answers to that question, unfortunately. It could be that the EIA test is a false positive, or it could be the RPR is negative. In those situations, we recommend starting again with a different RPR test and then confirming with a direct treponemal test. Our clinic has changed from our Trichomonas treatment in female patients to metronidazole 500 milligrams twice daily for 7 days due to resistance. Can you comment on emerging trick resistance and the anticipated changes in the STD treatment guidelines? And unfortunately, this is a big problem, and your institution is not the only institution that has changed from a single dose to 500 milligrams twice daily for 7 days. I think we will continue to see resistance to metronidazole, and I think more importantly, I am very concerned that those patients that are supposed to take it twice a day for 7 days are in fact not going to be taking the full dosing. So I think it is a question with resistance and a question with noncompliance. Oftentimes a single dose was nice because they could take it at the time you were seeing them, have an observed dose and be done. The 7-day dosing does worry me quite a bit, and I do think we will see some more resistance in the future. But we'll have to keep looking at it and see what the outcomes were for those that switched. I think I lost one over there. Okay. The next question is there a tie to decreased condom use amongst populations because they think all these diseases are now treatable? So the answer is I don't know. I think when you think about a youth population, what they do on a Monday and what you think about on a Tuesday and Wednesday are often seem to us to be unrelated. So there are days that they will use condoms, days that they won't use condoms, but if you ask them, you not use a condom because you thought that I could treat your infections, that's not necessarily why they didn't use a condom. So I don't think it's because they think they're treatable. I think they don't even consider STIs as an infection. If you remember the earlier slide, when asked, did you have an STI, about 15 to 20% of those youth who did have an STI said, nope, I didn't. So I think that whole question about using condoms and treating infections and thinking they're treatable are almost not related. So the next question is, what about the use of doxycycline as PrEP for syphilis? So I think that I'm not sure that we should even be thinking about PrEP for syphilis. I think that sets us up for a bad outcome. We would wind up having a huge amount of antibiotic overuse and resistance, and then be missing the cases that we needed to treat for with the doxy, and then those patients will come up with resistance. So I personally am not in favor of doing any PrEP for an STI outside of HIV, but I think caution about who has an STI, treating them and testing them, and then treating them would be the better way to go. Overuse of antibiotics is what we're seeing now, and using antibiotics for PrEP for STIs will make a bad problem perhaps even worse. So the next question is, can a person contact Trich through a person who was orally infected? And the answer is they probably can, and that is something you should be talking about them as part of your intake, as what type of sexual practice they are having, and then of course looking for the pathogen and then treating it. The next question is, how should one interpret a syphilis EIA? I think we've talked about that one already, so I apologize. Okay. I apologize, I'm reading fast. What are the tests for diagnosing neurosyphilis? And the answer is you can do an RPR and an FTA, but at the end of the day, you must do a lumbar puncture. And the correct test for a lumbar puncture is a CSF VDRL, not an FTA. So ordering the right test from serum is important, doing the lumbar puncture is important, and ordering the right test for the lumbar puncture is equally important. Doing the wrong test will give you a false negative, and you really won't know where you are. Okay, I think someone is typing here. It says PrEP also requires regular STI testing. So the higher rates being seen may be a function of better testing, a wider scope, or population that has otherwise not been tested. That would be great if that was the right answer. We're testing more, therefore we're seeing more, hopefully we're treating more and their partners, but I do, of course, get concerned that we're seeing more resistance, and some of the numbers we're seeing are because of failure of treatment. Okay. The next question is, can you speak to identifying signs of adolescent sexual abuse? What are the next steps in mandated reporting? So for this question, I think the first is understanding what in your state you are obligated to report, who to report it to, how to talk to the families, obviously always talking to your adolescent alone, not with the parents or a partner in the room, and then doing the right thing for the patient who is there. I think if you think that someone is being abused, you must report it, but you must also tell the patient you're reporting it. You must treat them and document everything on the chart, because afterwards, if you didn't write it down, you and I both know it never happened. So I don't know if that answered your question, but I think that it is something that we all worry about. We, unfortunately, have seen young adolescents that are part of trafficking here on Long Island, and it takes us a bit of extra understanding to think about if this young girl has come in a couple of times and has different boyfriends, is she in fact being trafficked? Is there something else going on that she's just getting new or repeated infections? So having a little bit of extra time and being able to look on your EMR and seeing if this is the first, the second, or the third time this patient has come in will also help answer some of your questions. See, some people are typing still. Okay. So for the repeat question of neurosyphilis, my recommendation is to go back to the CDC guidelines and take a look at, they have a very lovely table about how to diagnose syphilis, particularly neurosyphilis. And it talks about the different tests that you do, what you should do, what you shouldn't do, as well as the appropriate treatment for them. So the CDC guidelines not only have a table for neurosyphilis in adults, but also talk about diagnosing syphilis in the neonates. So if you have a population that you are considering, looking at guidelines, I believe, is always a help. All right. The next question is, I work in a local health department, and an overwhelming amount of the clients we see report never using condoms, decline them when they're offered. Is this a trend you see as well? And unfortunately, among youth, we see that trend quite frequently. They look at us like we have two heads when we say, didn't you want to prevent this infection? Use a condom. And they look at me going, no, I don't need to use a condom. Is it because they know I can treat them? Or is it because they believe they're supermen? It's probably a little bit of both. I wish I had the right answer for you, but smarter people than you and I across the world have not been so successful at getting patients to use condoms. Maybe we need a better answer to that one. I don't know. The next question is, in a low-resource setting without ceftriaxone 4GC treatment, what's the next best option of treatment? And the answer is it really depends on where you are. Most hospitals and most Department of Health, even in low and middle income countries, will actually have an annual report of the resistance profile of the GC isolates in the Department of Health. Instead of answering that shotgun, I would say, please look at those reports. They're available on the online, and they're available from WHO as well. You can look at it and get a snapshot of antibiotic resistance and then pick appropriate antibiotics. Without looking at the data from your country, it's hard to say what is the right answer. Can I comment on the rapid testing kits for STIs? And the answer is there are many out there. It's important to look at the kit's sensitivity and specificity for each of the pathogens you're testing. And if the sensitivity and specificity in that 80+% range, they're great to use. If it's below 80%, they're not good to use. Each one of those kits will have a package insert that talks about the data that led to the licensure of that kit. Look at that before you use it. Okay. And I think that's pretty much all of the questions that I'm seeing here. I will hand it off now to the IAS people, and we will move on to the next set of slides here. Okay. The webinar will be available on demand viewing in CME Credit on the link that you have here. CME Credit cannot be claimed for both the live and archived versions of this talk. You only get credit once.